All right, we're here. Let's go ahead and get a start on our shoulder impingement dry needling webinar. It's part of the Haynes method of neuromuscular dry needling, part of the Haynes PT Institute. So let me pull this up here. This may be a little bit more brief today. I'm going to try doing this just a little bit differently, but I really want to make sure that we hit all the nuts and bolts that you're going to need to know about dry needling of rotator cuff and the impingement associated with that. Brief history of dry needling. So people on these webinars are either veteran dry needlers or somebody who's just interested. And so this may be relevant information. You may already know all of this information. So what we'll start with is the brief history of dry needling. That's been used traditionally by European PTs for decades. And that part of the world is referred to as acupuncture. Differentiate that from traditional Chinese acupuncture. Here in the States, dry needling really originated from the work of Janet Travell and her trigger point theory. Obviously, traditional Chinese acupuncture has been around for thousands of years. First formal training course in the U.S. is 1997. I'm here in Texas. Texas Physical Therapy Association approved its first dry needling course in 2008. And then we finally got a definitive Attorney General opinion in 2016, affirming that dry needling is within the scope of practice of physical therapists. Each clinician in each of their states, their localities, will have to review the Practice Act, the laws in your state to determine if in your area it is deemed within your Practice Act. APTA has position statements out affirming that it is within the scope of physical therapy practice. I'll say that in my view, in my opinion, it is one of the best tools that we have to literally put our hands directly on the target tissue that we're trying to make an impact on. So how does dry needling work? Research ongoing concerning the physiology around the response to dry needling. Generally speaking, it's agreed that dry needling will, number one, increase blood flow in the area. That should say area, not R. It'll decrease taut muscle bending and the tenderness or sensitivity associated with them. Whenever I'm doing an evaluation, what I'm looking for is that tightness, that tenderness, that target tissue. The injury, the pathology may specifically be in that tissue, or it could be what I'll term a recipient of a pathology, either proximally or distally. Either way, that is the tissue that we're looking to have an impact on. That can decrease the spontaneous electrical activity or the twitch response that some of my colleagues strive to achieve. Some research does suggest that the twitch response may not be relevant for successful outcomes in dry needling. Different schools of thought. I'm not a trigger point guy. I'm not looking to get that twitch response. I'm not going to teach to multiple pistoning efforts to find that twitch. I find that we can do just as well without do that. So we can also see some CNS and some biochemical changes that can occur, suggesting that there are local changes, but also more distal and more proximal changes as well. Some general information, general contraindications, non-consent from the patient, obviously, medical legal reasons to stay away from during first trimester of pregnancy, the nipples, umbilicus, external genitalia, a number of other areas to stay away from up in the suboccipital region, somebody with a Chiari malformation, if they've got implanted electronics, pacemaker, defibrillator, anything like that, need to stay away from that and into a site that has some post-surgical lymphedema going on. Relative contraindications, the post-surgical situation, good frame of thought, 6 weeks with communicating tissue and then 12 weeks in the local area just to reduce the potential for infection. Obviously, you can communicate with the surgeon and if they feel it's appropriate to needle that before those time frames, then that's their call. But this is a good general time frame. Just some general precautions. If somebody has a significant needle aversion, if they haven't bought in, if they're really fighting the idea of somebody sticking needles into something that hurts, then the outcomes may not be as good as they could be. Someone with a significant cognitive impairment or communication barrier, the biggie here in and around the thoracic region is the pneumothorax. We will, dealing with a couple of structures, be close to that area. So definitely we want to use our guidelines to stay away from potential of creating a pneumothorax. Additionally, an area of a breast implant, when we're talking the spine itself, if there's been a laminectomy, surgery in and around what may or may not be our backdrop, want to be cautious of their scoliosis as that vertebra twists from concave or convex one side or the other. Obviously, that vertebra is going to rotate, and so our depth onto the lamina is going to change significantly there. So just something to be cautious of and aware of whenever we're dealing with the spine. So with shoulder impingement, this is not everything that could be an impact with the shoulder and the rotator cuff and impingement specifically, but the possible structures. The primary muscles, I've listed all four of the sits muscles, but really and truly for impingement itself, supraspinatus, infraspinatus are going to be your two biggies. Subscap and teres minor probably won't have much of a role with impingement there in the shoulder. The tendons and ligaments, coracoacromial and the trapezoid ligament are the two that tend to be of issue of concern dealing with impingement itself. If surgeon is going in and doing a debridement, a decompression in that area, they'll take out the bursal, the two bursa, and they will also more often than not take out coracoacromial and even possibly the trapezoid ligament, just because they occupy so much space, and if they're inflamed, they can decrease that space as well. Coracohumeral and the conoid ligament probably less. However, we can needle them for this and for other issues related to the AC joint out there. Some secondary muscles and structures, the rotator cuff, the myotendinous junctions, where if we are dealing with an impingement secondary to something else going on, rotator cuff tendinitis, which we frequently see in, clinically, we may need to look at treating that area. On the interior side, frequently see issues related to the short head of the biceps and the coracobrachialis. If it is more onto the glenoid itself, as far as your location of pain, then you could look at the long head or the bicipital tendon in the groove. AC joint itself can be needled, and we'll look at that briefly. And then also the subdeltoid, subacromial bursa, which really are contiguous with each other, being a big factor of a space occupying structure that, when inflamed, decreases that even more and creates more of an impingement situation. So these are the things that we'll look at as far as what we can use with our traditional therapy, with our manual, our hands-on stuff, and then what can we augment and supplement with dry needling to get a really good response. I use dry needling for impingement very extensively. We see a heavy volume of shoulder, rotator cuff impingement patients, and the dry needling is a really nice piece to add on to really get past that impinged location. Obviously, you still have to go through your flexibility piece, through your restoration of normal mechanics, and regaining strength back into those structures, getting proper scapulohumeral rhythm, and but the dry needling piece really speeds that up, lets us get to that traditional piece much faster. So I'm going to drop down here and I'm going to do a new share. I want to take just a second and look at the relevant anatomy that we're going to deal with. Come on, there we go. All right, so let me jump in. Having a little bit of a internet problem, but hopefully it won't be too terribly bad. So let's start just looking at the muscle piece initially. Like I said, teres minor, teres major, subscap on the anterior aspect probably don't play that big of a role, simply because we're talking about impingement, and really and truly supraspinatus is the biggest aspect. Infraspinatus seems to always have a tender spot as it runs just below the spine of the scapula here. But as far as, well, actually, let me look at one more. Well, let's cover this, then we'll come back to that. So as far as surface anatomy, with this particular protocol, things that we really want to be aware of. Number one, we must be able to identify the spine of the scapula, because supraspinatus is going to sit anterior, infraspinatus is going to sit inferior. Very relevant. We're going to want to be able to identify the distinction between the acromion, the lateral acromion edge, and the head of the humerus. Another important part in the AC joint, we're going to want to be able to identify that anterior and posterior, but really the anterior V-notch is represented here. And we mentioned the coracoacromial and the trapezoid ligament, and their role in occupying space there. Definitely want to be able to identify that, because we'll show how we can just drop down, needle into those structures, and hopefully elicit a response as far as pain there. But let's also look at some of the tendons and ligaments that we're going to talk about. So most definitely, we're concerned about the subdeltoid and subacromial bursa. Again, in this illustration, it shows them as two distinct structures. Really and truly, they're contiguous. It's one piece. However, we will look at different ways of needling into the bursa itself that can target each one individually if that were the case. Other ligament of concern also, the coracoacromial ligament, and then trapezoid ligament. We will, in practical application, we'll go ahead on my subject and needle into the AC joint. Not that uncommon to have some history of either some osteophyte formation, some bone spur inferiorly here, or if it's a sports injury, which is what this particular case was, have an AC separation. So issue there for the AC separation. Again, the trapezoid ligament can be at fault, or the conoid further on the posterior aspect. In this case, we're just going to needle down into the AC joint. So again, surface anatomy, spine of the scapula, the acromion, anterior, posterior V-notch, and being able to palpate down the length of the clavicle itself. Those are the main things here. Really and truly, I tell both patients and I tell my clinicians, shoulder impingement it's a really fun, it's a really, I don't want to say easy, but there's only so many potential issues that can go on here. There's only so many structures, and that gives us as clinicians, and especially as dry needling clinicians, a really nice path to treat that. So let me come back to this. All right. So now let's talk about using the needles and so forth. So supraspinatus, and I'm just going to make this kind of quick. So when I teach these courses for first-time needling someone, I always want them in prone or supine. And the reason for that is I don't know if they may have a strong vagal response. They may have some dizziness. They may get lightheaded. I've had people pass out. And so before I know their tolerance to dry needling, I may go ahead and place them in a prone position. In clinical application, once I get a good idea for that, absolutely, most of this is done in a seated position with me right beside the patient. On the supraspinatus, we're definitely going to look at spine of the scapula. We're going to move a little anterior. We're going to needle in an anterior to posterior direction to make sure that we don't enter into the lung field. This is definitely one that we want to be cautious. We're For infraspinatus, we're just going to drop down off of the spine of the scapula, maybe just a finger breadth, and we're going to needle anteriorly into the infraspinous fossa. If we were doing subscap, there's several ways of needling subscap. If they are in a prone position or any seated as well, with the hand behind the back, let that scapula wing, you can get underneath and needle into subscap there. You can have them come with hand over head, and as the picture illustrates here, you can get the bulk of the muscle again on the anterior aspect. You want to be cautious here to get, now this picture only shows with the arm down. With the arm up, the neurovascular bundle will pretty well be out of the way, but you definitely want to be able to palpate that location. Dealing with the myotendinous junction, it can also be needled right at its attachment onto the humerus as well. So depending on what you're going for. Again, for impingement, subscap really usually isn't involved that much. Similar, teres minor. For rotator cuff, every once in a while, it could be problematic, but typically it's just there along for the ride. So that one can be needled off the upper third of the lateral border of the scapula. You just go in there and you use your fingers as a backdrop, needle down into that. Again, for shoulder impingement, not that relevant. I do have in the tendons and ligaments of the shoulder. So apparently I borrowed that slide. I'd already had it narrated. Okay, so we'll look at the ligaments. Again, the AC joint ligament there, it can be needled directly in there, depending on the distance from the end of the clavicle to the scapula. It may be very small, but if you can get that space to open up, I've seen very good results with AC joint pain by just needling vertically down into that AC joint. Coracoacromial ligament, again, one of the main ones that gets surgically addressed if there is an impingement. And the trapezoid ligament, again, further. So coracoacromial is about 1 finger breadth from the lateral border of the clavicle at the anterior V-notch. Move over 1 finger breadth to get to the coracoacromial. For the trapezoid, we'll move 2 to 3 finger breadths into the crook of the clavicle here. Both of them will be slightly posterior with the needle. They are superficial, so want to be cautious with depth there. Coracohumeral ligament, we can also come off that V-notch and straight down into that coracohumeral ligament unless it's significant. Inflammation shouldn't be all that significantly involved, but if it is, we can address it. And then the conoid ligament from the posterior aspect. This would have more to do with AC separation. We could needle into that to see if we could stimulate that needle to thicken, to tighten up. Again, coming 3 finger breadths from the posterior V-notch. Subdeltoid bursa. So we'll look at the subdeltoid and the subacromial. Again, should be considered one contiguous structure. If there is point tenderness on the lateral aspect, it could be a tendinous issue, or it could be the bursa itself. So we can come 1 finger breadth lateral and then drop completely vertical into that subdeltoid bursa. For the subacromial, the key issue here is we want to make sure that we find the true lateral edge of the acromion. Some people, it's very easy to palpate. If there's significant muscle bulk in the deltoid, it can be challenging to really palpate and find that space. So what we're really going to look at is maybe a 5 to 10 degree superior inclination from underneath the edge of the acromion, and we're going to direct that needle into the supraspinous fossa. So going through there, we very well may catch subdeltoid, subacromial, bursa. We may, depending on where we come in at, we may catch some of the coracoacromial ligament. We're definitely going to catch supraspinatus as we're going in there, and depending on the angle, we may even catch a little upper trap. Our main goal, though, is subacromial subdeltoid bursa. One thing that we also mentioned, I mentioned I'd had a previous webinar specifically over tendinitis of the rotator cuff. So basically, with that, out here at the myotendinous junction, we need to look at, again, supra, infra, subscap, fairly common with the tendinosis in this area. So we can just hit that right at its junction, both so a little bit further away from the attachment for the tendinous junction, myotendinous junction, or at the tendinous attachment onto the humerus itself. Get really good response with that, even if there's a moderate sized tear. If we can get that muscle to relax and mechanically work more efficiently, then that pain seems to diminish. Here we're more talking about specific impingement without issue of the tendinitis. The main difference in these two approaches was we may need to go ahead and add this piece if this is the source of the inflammation that's creating the impingement. Something is creating the impingement. It could be a bone spur. It could be this tendinitis piece. It could be just a simple strain. Could be the bursa itself. It could be a full thickness tear. Either way, we have to find out what that is, and then needle one for the location of the pain itself and tissue restriction, and then two, what's causing it, and how do we go about that? Needling can be a great plus to that. Get through that first stage, get the pain down, and then get us on to traditional therapy again.
Okay. All right. So let's talk about shoulder impingement, subacromial, subdeltoid bursa issues. Always, first, what we'll do is catch the muscles that are attaching out here. We can include teres minor, but it doesn't really have that much of an impact here, as well as subscap. So we'll focus on supraspinatus, infraspinatus, and then some other structures. So supraspinatus will drop off the spine of the scapula, drop into the supraspinous fossa, down to its depth. We'll take a position just inferior to the spine of the scapula for infraspinatus. Very good. Now, one that frequently gets overlooked is the bursal components. So subacromial and subdeltoid bursa, we frequently will needle them as two separate units, but truly they are contiguous as one specific unit. So I'll find the lateral edge of the acromion. Got some nice muscle bulk there. And I'm going to take a slight superior angle to needle underneath the acromion above the head of the humerus into the bursa, and we'll also end up getting a little bit of supraspinatus again as well. In this approach, I'll get the needle in that location, do a little unidirectional rotation just to stimulate that bursa. Not always involved, but this particular subject is having some AC joint pathology. So we'll follow the clavicle over to its attachment. We'll find posterior V notch, anterior V notch, and we'll just drop straight into the AC joint. There. That's definitely superficial. So a shorter needle for that. And then we'll come and frequently, so surgically, if we come in and the surgeon decides to do bursectomy, decompression for impingement, they'll always, or almost always, remove the coracoacromial ligament, maybe the trapezoid ligament. But we can needle that as well. So again, we'll find anterior posterior V notch. We're going to move one finger breadth medially along the clavicle and drop a little bit posterior, this is superficial, into the coracoacromial ligament. So right there, frequent site of inflammation. A lot of other potential structures that could be needled here. This is always my go-to, my starting spot. Supraspinatus, infraspinatus, the subacromial subdeltoid bursa, and then the coracoacromial ligament. In this case, the AC joint ligament and space as well.
So fairly simple, fairly straightforward. It doesn't take a lot of time to get into that bursa. It does take some practice. It takes some skill to get the right angle so that we don't just end up onto the humerus, or we don't just end up on the inferior surface of the acromion. We want to be able to go all the way through that acromial space. We're only built with, give or take, about 9 millimeters of space between the head of the humerus and the acromion as it is. And so if there's already some decompression, or there's some inflammation in that area, it may be challenging to get that needle in there. But with a little bit of practice, it's a great response, great treatment approach for that area. There's some other exercise. There's some manual decompression that we can do to distract that. And I frequently will have patients do that in addition to my application of the dry needling protocol there. So quickly on dosage and frequency, how do you determine dosage and frequency? I divide most of these cases into 5 categories. And it depends on their activity level, the chronicity of the condition, response to treatment, and probably the most important factor is the compliance of the patient to a well-developed home exercise program. Dry needling is very important. I feel like it's a great tool, but if we don't implement traditional physical therapy skills as well, we're going to have a problem. If we don't have our patients doing significant work as far as their home exercise program, then outcomes are going to be poor. So we've got to have them doing these things. So we're looking at the 5 different classes. The athlete is number 1. 2 different stages here in the athlete. If they're coming in, they have no comorbidities, the issue is brand new. Within the first 10 days of injury, they have not had a significant deviation from the strength of their performance level, then here frequency of dry needling can be 1 to 3 sessions within the first 3 to 5 days. The prognosis is excellent. It should be able to return to normal training and performance within 2 to 4 days. Now, if there's 1 or more comorbidities, we've moved on to a subacute stage. They've thought it would just get better and weren't proactive about taking care of it. Now we're starting to have some asymmetries in strength, mechanics, and performance. Here we'll probably look at dry needling 3 to 6 sessions within the first 1 to 3 weeks. Prognosis is still excellent, but they'll need 2 to 3 weeks of training to restore any asymmetries, and then they can resume performance training. The average Joe, which is your weekend warrior, he's in decent physical shape, has had some sort of incident, resulted in strain or overuse injury. Here, we're going to need to dry needle 1 to 3 sessions within the first 3 to 5 days. Prognosis is excellent. They will definitely need to adapt an ongoing home exercise program to address whatever mechanical deficit that set them up for the injury in the first place. So if something was already there, went too aggressive, too strong over the weekend, inflamed something, we can knock the pain down, but we have to have them work on the right things to restore normal mechanics in order to move on past that. Then we've got the quick stick. This is your work colleague, somebody who slept wrong, somebody who just needs a quick fix. We're going to dry needle them 1 time, and I'm going to say that their prognosis is actually just fair. The reason that they'll have an underlying condition that really needs compliance with a home exercise program. They need to be doing something actively to address what's causing the problem in the first place. But they won't be willing to accept this fact, to be willing to do the work. So they're just hoping, and this is a lot of us, we're just hoping to do a little needling, hit the upper traps, whatever the case may be. There's a decent chance that this person will become what I call the procrastinator. The procrastinator, they have 1 to 3 comorbidities. They've been dealing with the pain or the functional complaint for several years. They're unable or unwilling to deal with the issue due to a variety of valid or invalid reasons. Now they've decided to do something about the problem. So here, we're going to need to commit to a full 8 to 12 sessions within the first 30 days. And prognosis is good, but success definitely depends on compliance with an HEP. If they get after it and they do their work, we can take care of this stuff. Lastly is the hard case. So here we have multiple comorbidities. There's severe OA or DJD, other issues that require surgical intervention or other interventions that just cannot be done due to either medical, personal issues. For example, they can't get cleared for surgery due to pulmonary or cardiac issues. So here, our frequency of dry needling for this population, we're going to go aggressively the first month, 8 to 12 sessions. In the second month, we're going to start weaning that down. We're going to see them 4 to 8 times during that second month. And then from the third 30-day period and beyond, we're still going to look at either one session a week or one session every other week. And prognosis here is fair. Let's be honest, this is a long-term maintenance case. Insurance may be an issue and require a cash pay situation. Treatment will be required until interventional clearance is obtained. Again, these folks, they need surgery, but for whatever reason, it's just contraindicated or they can't do it. And the dry needling can be a great way to reduce their pain. So this is specifically non-pharmacological pain management. The dosage may have to be adjusted based on their condition, and treatment should improve functional outcomes, but withdrawing or discharging the dry needling program will result in a return to their prior condition. There would be limited improvement with these folks with a really progressive, aggressive HEP. So I'm going to encourage you, if you have any questions about this shoulder impingement, again, prior to implementing dry needling into treatment of the rotator cuff, of impingement specifically, treatment was very challenging to get good returns within a rapid period of time. I challenge you to implement dry needling, especially the subacromial approach and the coracoacromial approach on the ligament to make a change with what's happening in your patients in that space. If you have any more questions about this, feel free to contact me. Go to the website, get me at the email. I will have this webinar recorded and placed on our YouTube channel. And you should get an email about that tomorrow, but I'll have that out later. For the remainder of the year, I've got 3 more webinars for this year. Next month, we're going to talk about and demonstrate plantar fasciitis, both the proximal and distal aspects. In November, we'll look at thoracic outlet syndrome. And then in December, we'll look at pes anserine bursitis, that medial knee complaint that we see so often clinically. But if you want to get in touch with me, I've got my phone number there, and the rest of that contact. See us on Facebook, Instagram. I will leave that information up there. If you have any questions, feel free to reach out, and look forward to seeing you again next month.